If you can't clean a device, you can't disinfect it. Let's say they want to take a biopsy, and they run forceps through that biopsy channel. That sharp metal biopsy forceps that's going down that channel is scraping that patient material off, and it's being discharged down into the inside of the patient, in the colon, the stomach, the lungs, wherever that the biopsy is being taken.
This is a key that could save your life or the life of someone you love by simply taking the time, literally a few minutes of your time, to ask this simple question. Colon cancer. No one wants it, but are the screening tests safe? Hi, this is Dr. Mercola helping you take control of your health, and today I am joined by Dr. David Lewis, who is a retired microbiologist with the EPA and whistleblower who exposed the massive fraud that is still currently going on at the EPA with respect to biosolids. So we discussed that topic in a previous issue, but this time we're going to work on another massive public health issue that he exposed in his book. And that book is Science for Sale. That's correct, right? Science for Sale.
That is correct.
So it's a difficult book to read because it's not really written as a novel like a lot of books are. This is more the dry facts, but the information in it is just astounding of what he exposes. I mean, Dr. Lewis is a man with integrity who basically put when he exposed the truth of what was happening at the APA, he lost his job. And he's a man who loves science. I mean, that was his whole mission. His passion was science. He got fired because he told the truth. So he's uncovered this other area, which I'll let you describe in a moment about the primary tool that's being used to screen for colon cancer. It's routinely recommended for everyone, I believe, over the age of 60, if I'm not mistaken, which is a flexible sigmoidoscopy or a colonoscopy. And they both have the same problems in that they're these very expensive pieces of equipment that are used on, they're not disposable, so they have to be essentially sterilized and used before they're used on everything. And the sterilization process does not sterilize. That's the problem. So we're going to go into the details and what you can do to protect yourself and your family from this potential problem, because I know many of our viewers are at the age where they're getting these screenings on a regular basis. So welcome and thank you for joining us again, Dr. Lewis.
Thank you, Dr. Mercola.
Why don't you describe what the standard procedure is and how to sterilize equipment, and maybe a little bit about that process, with these scopes. And were the scopes mostly the flexible sig scopes or the colonoscopes or both?
Both.
Okay.
And a variety of other scopes, like bronchoscopes for
sure.
looking in the lungs.
Or endoscopes, where they're looking in the stomach.
Yeah.
Endoscopies.
Gastroscopes are used to look inside the stomach as
Sure.
well, and the esophagus. These devices have several basic components. One is some long flexible tube to stick down your throat or elsewhere to look inside of the body, with a little camera lens on it, so that the doctor can real-time view the inside of the stomach or inside of the colon through a camera lens, looking for evidence of cancer or other conditions. On the other end of that scope, a number of knobs that you turn to manipulate the scope while it's in the patient. There are also channels, and this is the important part. There are internal channels. There's, in a flexible endoscope, there's what's called a biopsy channel, where the physician sees evidence of a tumor, for example. He or she can insert a little claw through that endoscope into the patient and grab a piece of tissue and pull it back out through what's called the biopsy channel. There's another equally important, if not more important, internal channel in these endoscopes that's called the air-water channel. while the camera lens is inside the patient, it often gets covered with blood and other patient material. So there's a little water nozzle close to that camera lens on the tip end of that tube that's inserted into the patient, where the doctor can hit a little button and it will blow a jet of air and water over that lens and clean it off. That channel is much smaller than the biopsy channel. The biopsy channel in all flexible endoscopes is fully accessible to a brush, so that when you're cleaning the device between patients, you can insert a long brush, like a bottle cleaning brush, down that biopsy channel and brush it all clean, because it's got blood, it's got mucus, it's got pieces of tissue from taking biopsies, all inside that channel. So it has to be completely cleaned out before it can be reused on the next patient. The big problem that we have always had with these scopes is that the little channel that air and water flows through, which also gets contaminated with tissue and blood and feces and all kinds of things, is not fully accessible in most flexible endoscopes. You can't get a brush all the way through it. And so the most common problem that a physician has when he or she goes to insert a colonoscope to look for colon cancer, or say a bronchoscope to look in the lungs, is they'll insert the tube into the patient, the lens gets dirty, and they go hit the little button for the air-water channel, and nothing happens. It's clogged up. So what the doctor has to do is withdraw the device and get another one. That is the most common problem, and it happens when the scope oftentimes is first inserted. So what's happening is the physician is inserting a scope into the patient that's so clogged up with patient material from previous patients that it's unusable. It's just, you can't get any air, water through it. Mm-hmm. So that's the problem we're talking about with these scopes today. It's different with dental handpieces, drills, and other attachments to dental devices. They can be thrown in an autoclave and heat sterilized. Flexible endoscopes cannot be heat sterilized. You can't cook these things between patients like you do normal surgical devices. So they
and the reason you can't is because they're very sensitive electronic and mechanical equipment that would be essentially destroyed if you heat sterilize them.
In short, the way I would put it is, you can't do it because the manufacturers haven't been made to do it. We can put a rover on Mars. Mm-hmm. Surely we can build a flexible endoscope you can put in an autoclave.
Okay, but they
There's
can't.
No pressure from the FDA to fix that problem.
I didn't so mechanically it can be constructed. It's just that there hasn't been an incentive to create one that would solve the problem.
That's right. That's all it is.
Were you able to document that transfer of infection the same way that you did with the dental equipment, though, with the flexible scopes?
Yes, visually it can be demonstrated, and what I did along those lines is got study initiated with a university where we looked at the internal channels, the air-water channel and the biopsy channel, and actually took samples of that channel, the little Teflon-like coating on the inside, and looked at layers of patient material on that and tested different ways of treating that layer of patient material to see what it required to remove it, to actually clean those channels effectively. So that was what our research focused on, other than we did publish a study in Nature Medicine in 1995 where we took the lubricants used in flexible endoscopes and exposed that to HIV-infected human blood and demonstrated that when you submerge flexible endoscopes inside of 2% glutaraldehyde, which is the most common high-level disinfectant that's used for treating scopes between patients, cleaning them, that it was ineffective. So using the same laboratory procedures we use for dental equipment, we found with flexible endoscopes, the same problems are there. Most flexible endoscopes today are simply submerged in 2% glutaraldehyde solution to disinfect them between patients. They're submerged for 10 to 15 minutes normally, which is below what the FDA recommends, and then reused. And we've demonstrated in the laboratory that you could submerge those devices for 2 hours and they're still infectious with HIV trapped in those lubricants.
So is there an alternative sterilization agent that can be used, a liquid?
Yeah, the problem here is one where the two choices that are out there boil down to two chemicals that are being used primarily. One is glutaraldehyde, which is like formaldehyde. It's just a smaller molecule. Formaldehyde is used for preserving frogs in a laboratory, for example, for display, something like that. It's used in embalming. Glutaraldehyde is used overwhelmingly. The most common procedure for colonoscope involves glutaraldehyde, 2% glutaraldehyde.
You say 75%, 90%?
You cannot go much higher than 2%.
No, I'm sorry. The number of...
the number.
Yeah.
Somewhere in the range of 80%
Okay.
of the time, glutaraldehyde is used for disinfecting.
And it doesn't work.
endoscopes.
It doesn't work even at the 2 hours.
It not only doesn't work, it complicates the problem. What glutaraldehyde does is the same thing formaldehyde is used for preserving frogs. It doesn't dissolve the tissue, the blood, the bits of flesh that are trapped inside flexible endoscopes. It actually preserves them so they build up over time. You're exacerbating the cleaning problem when you use glutaraldehyde. The other alternative, which is used on, at least the last time I checked several years ago, about 20% of the flexible endoscopes in the United States are reprocessed using peracetic acid. Peracetic acid is used in organic chemistry labs. When you have like a flask, a glass flask that has little tubes of glass attached that you can't get a brush through them, but you want to clean out old hardened organic matter. You can put them in peracetic acid and that acid will dissolve proteins, which is what you want to do. So one of the first things I did when I started looking at the problem with flexible endoscopes is visually inspect flexible endoscopes, these channels in them, to see what they look like. The little Gore-Tex tube that runs into the patient carrying either air, water, or a biopsy forceps for doing a biopsy sample. Those coatings are white when the endoscope is new, brand new. You can go into a endoscope repair shop today, any one of them, and whoever's working there, repairing and cleaning those scopes that have gotten severely cleaned, whatever, you ask that person, can they tell a scope that's been used with peracetic acid or glutaraldehyde? They all can. You can see it with the naked eye. in a flexible endoscope, the peracetic acid is used to clean. That material in that tube, coating that tube, is as white today after years of use as it was when that scope was bought. On the other hand, you look at any other scope in those tubes, by sticking a camera down those channels, just like you would looking inside a patient, what you will see is a very dark reddish brown coating. It's no longer white, it is very dark reddish brown, and that is a coating of patient material. So when they run, say they want to take a biopsy, and they run forceps through that biopsy channel, that sharp metal biopsy forceps that's going down that channel is scraping that patient material off. And it's being discharged down into the inside of the patient, in the colon, the stomach, the lungs, wherever that the biopsy is being taken. So it gives you some visual idea of what's going on here. If you can't clean a device, you can't disinfect it. Mm-hmm. It's as simple as that. Because the disinfectants can't permeate, they can't diffuse through those hardened layers of patient material.
If this is such an obvious problem with such clear implications as to what the consequences can be from not cleaning it and persisting in using the glutaraldehyde, why do you think 80% of clinicians and clinics continue to use it?
It's simply a matter of economics. In dentistry and endoscopy, pennies per procedure add up, and procedures that millions and millions of them are done routinely. So there's a lot of pressure at that level of what goes on in a hospital to save money. Sitting in the commissioner's office of the FDA, the FDA commissioner can write a letter and say, from henceforth, all air-water channels will be large enough in flexible endoscopes to get a brush all the way through them. That's just simple as that. And once the FDA does that, everybody working in the hospital with these devices is going to get a flexible endoscope you can stick a brush through the air-water channel in. It doesn't get simpler than that.
I'm wondering, with your knowledge and awareness of the specifics of this ineffectiveness of the vast majority of the sterilization process for the endoscopes, flexible scopes might be more accurate, what your recommendation or what you personally follow. I mean, is it possible to identify a clinic that uses the peracetic acid? And is that sufficient, or is there still, even when using the peracetic acid, is there still deficiencies in the sterilization process?
Just based on what I've seen with flexible endoscopes that are handled by repair shops, the scopes that I've used in my research for these kind of experiments that I described earlier, I am perfectly comfortable with having a colonoscopy or any other procedure using a flexible endoscope if it is cleaned with and sterilized with peracetic acid. Peracetic acid, the process used in the United States, is actually the only sterilization procedure approved by the FDA. It's a chemical sterilization procedure. It's not heat sterilization. But still, visually, you can see the patient material is thoroughly cleaned out. Mm-hmm. I'm comfortable having those procedures done. So what I do is simply check when my doctor wants to do a procedure involving a flexible endoscope. I explain I'll only have it done if it's done in a facility that uses peracetic acid to reprocess or clean the device. And so I double check myself in Athens, Georgia. I go and talk with the staff at the hospital where I have those procedures done, and make sure they are using peracetic acid.
Okay. So you don't want to prime them with the right answer by asking that. You want to know what the correct answer is, but my guess is if you want to get an objective, real answer to your question, you call the appropriate person. It may take a while to get through who's ever responsible for doing the cleaning, but it should be easy. Anyone should be able to get this information at the clinic they're going to, is to ask what agent are they using to clean and sterilize the flexible scope.
That's a good point, and that is exactly what I ask. I go in and ask, how do you clean these devices between patients? How do you clean your scopes between patient use?
And if you heard,
and I will listen to their answer.
And if you hear the word glutaraldehyde, as you will, in 80% of the clinics, you say thank you, but no thanks. Cancel my appointment.
That's what I personally do, and they usually don't say glutaraldehyde. They'll usually say Sidex.
Oh, Sidex, S-I-D-E-X?
Yeah, it's C-I-D-E-X.
Okay.
That's the most common form of glutaraldehyde used.
Okay. So if they give you a brand name, then you could easily go on the internet and look it up and see what it is.
Yeah, right.
Yeah, so that is the answer. This is a key. This is a key that could save your life or the life of someone you love by simply taking the time, literally a few minutes of your time, to ask this simple question. And you don't have to be damaged, hurt, or infected by the ignorance of the medical community. You just don't have to, because we've got champions like Dr. Lewis who have really done the research that shows really clearly that this is an issue. And then if it was brought to the attention of the appropriate FDA commissioner, this wouldn't be an issue. Everyone would be using it. It would be mandated, and it may cost another 25 cents for a procedure, but it's really worth it to have clean equipment.
It is.
Yeah, so it's just mind-boggling how atrocious our system is, and they don't pay attention to just basic, fundamental details.
It is so expensive to document these cases, it is almost never done.
Mm-hmm.
It's not on the radar. What does it mean to say there are not many documented cases when we don't have a way of routinely testing these things to document cases?
If you're not looking for it, you'll never find it.
You never will.
Right. You would. That's just common sense, but sometimes common sense is, sadly, not there at these levels that they need to be.
Yeah, tell me about it.
So you're the public. You're watching this. Now, I know there's many healthcare professionals, even better, because you have access to wider people, wider numbers of the public. So you've got to be aware of this issue. It really is important. It's a simple fix. Remember, if you are recommended by your physician to get one of these flexible scopes, either an endoscopy, bronchoscopy, flexible sigmoidoscopy, colonoscopy, you just have to ask someone in the clinic what the sterilization process is, what the cleaning agent is. Don't prompt them with the right answer. I don't know if it'll matter a lot, but just don't give them the right answer. You know what the right answer. It's peracetic acid, and that's the one you need to find out, the one that's being used. And only 1 of 5 clinics are using it, so you might have to contact 10 clinics to find one. Who knows? You might get lucky and find out the first 1 or 2, but you're most likely the vast majority are not going to be using this. So you've got to do your homework, and enough of us get ready to take this stance and absolutely refuse to have this procedure done with glutaraldehyde, a sterilized instrument. Then, listen, we vote with our pocketbooks. Those clinics' businesses are going to go down. They're not going to be doing procedures, and they are going to be motivated to switch their disinfection procedure. Thanks so much for watching. Remember, hit the like and subscribe button so you can get more videos that can help you and your family take control of your health.